This is an exciting time for osteopathic medicine. Some of us feel like we are really at a tipping point as we think about what our contribution to the U.S. healthcare system can be. And because of that visibility, interest is growing and applications have been high for students who would like to become osteopathic physicians.
Welcome to Off the Chart, a business and medicine podcast featuring lively and informative conversations with healthcare experts, opinion leaders, and practicing physicians about the challenges facing doctors and medical practices. My name is Austin Littrell. I'm the Associate Editor of Medical Economics, and I'd like to thank you for joining us today. Before we get started, just a quick note, Physicians Practice will be hosting Practice Academy's new practice management track on Thursday, March 19th. The virtual learning experience is designed for physicians and practice administrators looking for practical real-world strategies to strengthen operations, improve performance, and build more resilient practices. Speakers include Anders Gilberg of MGMA, Bronson Cox of Encoda, Justin Lamb of Cool Blue VA, and Mark Herzog of Veradigm. You can register today by clicking the link in the show notes or by going to registration.physicianspractice.com. That said, in today's episode, Medical Economics Senior Editor Richard Payerchin speaks with Dr. Robert Cain, a specialist in internal medicine and pulmonary medicine, and the president and CEO of the American Association of Colleges of Osteopathic Medicine. They're talking about the remarkable growth that osteopathic medicine has seen in the United States, from a single school in the 1890s to 73 campuses across 36 states today, enrolling nearly 30% of all U.S. medical students. Dr. Cain, thank you for joining us, so now let's get into the episode.
Dr. Cain, thank you for joining us today.
Thank you for having me.
Just learning about the U.S. healthcare system, one of the things that has been interesting in recent years has been to see that growth of osteopathic medicine. Can you review some of the current facts and figures about the number of osteopathic medical colleges, students, and degrees awarded?
I can. I think this is one of the most amazing growth stories. And if we actually go back for a moment in our history, the end of the 19th century, in the 1890s, there's a single osteopathic medical school in the United States. And when I came into this role just 7 years ago, there were 52 campuses. Today, we have 73 locations across the United States. So 46 main campuses. That means they have a named College of Osteopathic Medicine. Often those schools will open other locations. That's how we get to 73. Those are now, instead of one state for that initial one school, 36 states where we are currently offering the D.O. degree to those who are interested. In terms of the medical students who are enrolled at those campuses, about 3 out of 10, almost 30% of medical students in the United States today are earning the D.O. degree. And that adds up to almost 40,000 medical students at all of those colleges I was just talking about.
This is kind of a big question. We'll see what we can cover in coming minutes here. But how would you describe the current state of osteopathic medical education in the United States?
Well, I think to take a big question and make it actually very simple, we're growing. When we look at our visibility, we look at the numbers that I was just talking about, influence, reputation, all of those things are growing. This is an exciting time for osteopathic medicine. Some of us feel like we are really at a tipping point as we think about what our contribution to the U.S. healthcare system can be. And because of that visibility, interest is growing and applications have been high for students who would like to become osteopathic physicians.
In your own career, can you talk a little bit about some of the factors that really attracted you or influenced your decision to pursue osteopathic medicine? And then maybe part two, what are some of the students kind of bringing to the table right now in terms of why are they attracted to osteopathic medicine?
So for me, it was actually a very personal experience. I was working as an EMT part-time in Western Pennsylvania when I was going to college. And the community I was in actually had two hospitals at the time. There was a general hospital and osteopathic hospital because there was still some segregation of the two degrees at that particular point in time. I had gone to college fully intending to become a physician. Really didn't know a lot about osteopathic medicine. But my experience as an EMT going into each of those hospitals, I was intrigued by the osteopathic physicians. And what I enjoyed was their interest to pull me to the side, talk to me not just about medicine, but about osteopathic medicine. And that it was medicine based upon a philosophy, a way of thinking about how patients should be treated, how care should be delivered, as well as the use of manipulation, learning to use my hands, not just to diagnose, but also treat. And because of personal interests, the philosophical piece was very attractive. The manual medicine piece was very attractive. The fact that I could learn to do any form of medicine and surgery, and ultimately chose to go that direction. But we were a much smaller profession at the time. And as I said, still a segregated profession to some degree. I think when I look at today's students and I talk with today's students, it is that visibility, this idea that the location of the medical schools attracts me, but also more and more as we listen to our students, they're watching what's happening in the United States, this resurgence perhaps of a focus on health that really goes back to almost a century ago, but a different the thought that medicine could be approached differently and that we could have a health orientation instead of a disease orientation, and that's really been part of our identity from the very beginning and something that they think they'd like to be part of.
It sounds almost like a cyclical effect in the sense that as osteopathic medicine perhaps becomes more visible, more people are attracted to it, which then in turn makes it more visible as there are more osteopathic physicians.
It's self-propagating. I actually do believe there's a component to that. The fact that for a long time we were that single school, then a small group of schools in the middle part of the United States. But now, as I said, 36 states have colleges of osteopathic medicine. So a student can look and say, well, do I want to apply there? It's close by. That makes sense to me. But more so than just that is the idea that listen to the mission, listen to the mindset, and understand that we want to put patients back in the center of healthcare where they should be, which should be care delivered in a humanistic way that focuses on the patient first and the problem second.
It's an idea and a philosophy and method that I think absolutely does sound attractive in medicine. And apart from the clinical side, we'll talk about some of the financial issues and economic issues too, because in late 2025, the association published an economic impact report. How did that report come about?
Well, one of the things I don't usually do is focus and talk about me, but I actually have to do that in this particular case. A few years ago, I started looking at our growth and thinking about our future and asking questions of the leadership across the osteopathic community. And the scenario in question ultimately ended up looking something like this. If we were to awaken tomorrow and all evidence of osteopathic medicine were suddenly gone, what would be missing? What would be hard to replace? And who would care? And what the conversation was really about is what is the value we bring to the healthcare system? There are two degrees, two separate medical degrees in the United States, and maintaining that is a challenge. There's a cost to that. There's work to be done to have those two separate pathways. So why are we here? And what is it that we can make a difference in the healthcare system because of our presence? And as I started looking for the data to really guide that conversation so that we could have it more effectively, we started realizing we needed more data. We needed more numbers. So what we're actually doing, what you're referring to, is the first of two reports. So one is a workforce and economic impact report. The other is a research report. What is the work being done by our colleges of osteopathic medicine that focus upon the tenets or the principles of osteopathic medicine? So we can think about how that's impacting healthcare overall through the research side. The workforce report and the economic impact is to look at, by producing these physicians who practice with a certain mindset, where are they going and how are they therefore then influencing the local healthcare as well as the local economy.
To continue in some discussion about that workforce and economic impact report, what are some findings from that report that you would like to highlight?
We are particularly happy with the results on primary care. We've talked for a long time about the positioning of osteopathic medicine around primary care, the role it can play. When you look at our principles, one of which is this focus on body, mind, and spirit, as well as the others, it's not a surprise that whether you enter primary care or that you would take that into primary care. It aligns very well to what happens in primary care. But it's also very aligned to some of the high need specialties as well. So one of the findings of the report that's exciting is that roughly 50% of our graduates, if you look at all the colleges of osteopathic medicine, are going into primary care. Every single one of our colleges exceeded 45% of their graduates doing so. That's more than twice that of our colleagues. Very needed in today's healthcare system. But we also were able to show that about 25% of our graduates are going into high need specialties, areas like general surgery, obstetrics, psychiatry, things that are also important to maintaining that general health. We're very pleased with the fact that our colleges are placed, over half of them are placed in medically underserved areas. That's going to be important to trying to change healthcare delivery in those, especially if we talk about graduates ultimately staying and practicing in the areas where they've trained. About half of the colleges are also in rural adjacent designated areas. So counties where at least 20% of the population is designated as rural. So we were really happy to see that. We're also pleased with the rural placement number so that our graduates are training in the areas where we want them to train and then staying in those areas, in particular rural areas. And so some of the colleges of osteopathic medicine had fairly high numbers of students who have remained then ultimately in rural settings. Also, I think a bit of information around our community-based model. So we tend to use a model where we place students into community institutions where they can become uncommonly good at the common things, where they become part of those communities. And hopefully by doing so, both through medical education and then graduate medical education, they're more likely to stay there in practice.
You know what, Doctor? I was going to say you touched on a couple of points that any one of which could be its own conversation. If I may, and I don't want to belabor the point, but we'll talk a little bit more about primary care. And you've touched on this in our conversation so far. Doctors of osteopathic medicine do play a huge role in primary care in the United States. Can you elaborate a little bit more about how that happened historically, and do you anticipate that will continue in the future?
So if you go back to the origins of osteopathic medicine, and I've referred to these tenets or principles, as I said, one of the first tenets is the idea that the individual in front of you, the person that you're going to take care of, is a combination of body, mind, and spirit. So from the very beginning of medical school, we try to embed that into the training and into the mindset of the students. We expose them throughout medical school, both in the first 2 years, where they're predominantly in the classroom, and then in the third and fourth years as well, to primary care physicians and to settings that promote primary care. Now, that's not because we expect everybody to become a primary care physician, but what we think, and certainly data help to support this, is that if you train someone with a generalist mindset, they actually perform better even as specialists later on, right? It gives them a real appreciation of what that entire system needs to be. Sometimes I'll refer to that as a complexivist mindset, right? Rather than breaking things down into their smaller parts, we want to think about how they actually go together. So I don't think it's a surprise that at the end of medical school, that it impacts students going into primary care. But the fact that our schools emphasize the importance of primary care throughout the 4 years of the experience, so that we're sort of trying to nudge students in that direction. We also try to select them so that we think the raw materials are there for people who may be willing to enter primary care. And I think the data, as we just talked about, show that we've done a pretty good job. The question is, what's going to hold true for the future? And I think the challenge is we're swimming upstream in this space. The forces around us in the system have until recently not really supported primary care and work to push people away from that particular space. So we continue to advocate for better reimbursement for primary care physicians, for better working conditions for primary care physicians, for better respect for primary care physicians. And if we can elevate those things and we continue to do the things I talked about, hopefully we can keep our numbers high as we go forward.
Doctor, I always tell people in full disclosure, I'm not a physician myself, but in as part of my job, one of the things that I find fascinating is this sort of continuing dichotomy, if you will, of specialty care, which focuses on just one element of health in a human being, and then sort of the general interaction about how one system in the body, and ill health in one system can have adverse effects across many other systems. So it becomes a matter of both specializing as well as looking at sort of the big picture of health. And I think that's really fascinating.
Well, sometimes people ask the question, well, you're a DO and you're a lung specialist. Well, yes, I practiced pulmonary medicine. But what I brought to that was everything I've been talking about, to try to understand the person in front of me, their whole story, right? Because everyone comes to you with a story. It's not just the symptom or the complaint. If you really want to take care of that patient, then you have to understand that patient. And as you begin to do so, it gives you the opportunity to more effectively care for them. But we also have to think about when I treated lung disease, what are all of the peripheral things that, if they're not fully treated, aren't going to help that patient be as functional and as healthy as they possibly can be. So just a quick example, if oftentimes patients who have chronic disease, like lung disease, will have mental health issues like anxiety or depression. Well, if those go untreated, they may not get the same outcome as if they were treated and they were addressed. So we want to make sure we're paying attention to that entire picture. And I think by having an osteopathic education that from day one was focused on know your entire patient, be ready to take care of your entire patient, not just the single pathway of what's happening with their lungs, it makes a difference in the health outcomes.
Hey there, Keith Reynolds here, and welcome to the P2 Management Minute. In just 60 seconds, we deliver proven, real-world tactics you can plug into your practice today, whether that means speeding up check-in, lifting staff morale, or nudging patient satisfaction north. No theory, no fluff, just the kind of guidance that fits between appointments and moves the needle before lunch. But the best ideas don't all come from our newsroom. They come from you. Got a clever workflow hack, an employee engagement win, or a lesson learned the hard way? I want to feature it. Shoot me an email at kreynolds@mjhlifesciences.com with your topic, quick outline, or even a smartphone clip. We'll handle the rest and get your insights in front of your peers nationwide. Let's make every minute count together. Thanks for watching, and I'll see you in the next P2 Management Minute.
Doctor, at the risk of jumping around a little bit here, I wanted to return to the report and the Workforce and Economic Impact Report, only because there was a key finding involving the number of jobs and other economic effects that are supported by the member institutions. How would you describe the economic effect that the colleges of osteopathic medicine have on their communities?
Maybe I'll make just some broad comments first to answer that question and actually tell a very specific story. It was exciting to see some of the numbers that the number of jobs that are generated when you open a new college of osteopathic medicine, and recognizing that some of those jobs are new educators you may be bringing into the area, people who are going to teach, might be PhD, EDD, DO, MD, who are going to become part of that school. But it's also all of the other people that are necessary to make that institution work. And so the school itself creates jobs. And then in the community, there tend to be new jobs that are created as well. Now, I already mentioned to you that over half of our schools are in medically underserved areas, and a fair number are touching on rural adjacent communities. all communities need jobs, but what better place to create jobs than some of those? And we could go through the names of where are our schools located in smaller rural communities that hopefully we've actually been able to make a difference. But there's one example I always use because it was for me a very personal opportunity. Pikeville, Kentucky, in rural eastern Kentucky in coal country. And many, many years ago, I was invited there to potentially join the initial staff as they were opening this medical school in the mountains, as they called it. And there were people who thought, how can you open a medical school here and what is it going to do? And I remember visiting Pikeville for the first time as it truly was a rural community with a small college. And over the years, as I didn't take the job, but over the years, as I would go back and I would visit, I was watching this transformation in that town as that initial College of Osteopathic Medicine brought not only those new people to that school, but it caused them to have a resurgence. You go down to Pikeville now, and it's a vibrant city with a vibrant hospital that wasn't there in 1997. And the only thing that changed was putting a College of Osteopathic Medicine in that particular space. So the good thing about this report is we see that repeated in other places. Bring a College of Osteopathic Medicine to a particular community, you can expect to see new jobs and changes in the economics of that community. But one of the other things that's really important is the fact that nearly 40% of COM graduates, if you look at all of the data, actually stay in the state where they've trained. If you're a state that's been underserved, we have some new research not included in this particular report that actually shows some of those medically underserved designations disappear within a few years after that college opening, because we brought new doctors to that community, not only who are going to teach in the medical school, but who are actually staying after they finish their training. So we get to make a difference in people's lives.
That's a really neat example of an actual place on the ground. People can, look up on the map or do their Google search and learn more about Pikeville. That's a fantastic effect. So I hope that continues. And if there are additional openings there, for colleges in the future, that will continue as well. I had a question for you. We try to sometimes we leave our timing a little bit vague, but literally today, as we speak, the White House had announced the Great Healthcare Plan, and where I'm going with that is that especially at the federal level, and then you've got 50 different states to keep track of. Policy is always changing. What are some policy changes, either at the state or federal level, that you would like to see that could really help osteopathic medical education?
So community-based education is challenging to operate. And when we look at so many of the institutions where our students train, their margins are small. Sometimes there's no margin at all. And we're asking them, on top of worrying about taking care of their community, to also train medical students and to enter into the education space. And sadly, when we look at decisions that are often made when those challenges begin, the first thing that goes is education. And so we do have one program we're currently working on called the Community Teams Act, which is trying to direct more funding into some of these smaller communities where we're training our students so that you can actually support the preceptors, the physicians who are doing the teaching. And that's important because they're busy trying to take care of patients. And teaching, the sense is that they're giving something up. And for a long time, that was always done for free. But as healthcare has changed, it becomes hard to be a teacher and a practitioner. So finding ways to better support those communities from a funding standpoint into the teaching institutions, helping to make those local hospitals into teaching institutions for the type of model we use can be incredibly important. And so we do have a lot of advocacy work that is addressing that particular issue. The other I mentioned earlier in the call is that unfortunately primary care has for far too long in our system, both at the policy level and at the operational level, not really given the value to primary care that it should have. We talk a lot about primary care and the need for primary care, but we don't value it in the way that we need to. And I think that there's opportunity in the policy space to help to do that. And part of that is by leveling some of the playing field in terms of the compensation. It is hard to be a primary care physician, and working to ease some of the burden that they currently experience could help not only with their own well-being and the care delivery, but with those people willing to be preceptors for our students.
Currently, there is a movement to make America healthy again. In a larger sense, how will osteopathic medical education fit in with that movement?
We've been trying to watch this very closely because so much of the conversation actually aligns to the principles and practices that I've referred to, right? So osteopathic medicine has a whole person health preventive mindset that's really been with it from the beginning. A recent conversation that we've been involved with HHS has been around nutrition. And that's a natural conversation. If we think about what goes into our bodies as fuel, are we getting the right building blocks into each of us as individuals on a daily basis to promote health? And if we're lacking the right nutrients, if we're lacking the right source of fuel, then it makes sense that, and we certainly know this from research, that disease develops. And so having an actual opportunity to see some emphasis on things like nutrition, sleep, exercise, as part of a big portfolio of how do we care for our patients. What I always thought worked so well for me as an osteopathic physician, and again, back to your question before, what attracted me to it was the idea that we could learn and focus on how to keep a person healthy. And when they get sick, we had the tools to try to take care of them. And that makes a pretty comprehensive position. So the conversation is valuable. And I think that what we have to push for is it's okay to ask questions about the practices we have today. But let's do the research to make sure that the answers we're getting allow us to actually do the best job we can for our patients.
You know, doctor, comes up, I think, in every interview, the question about the Make America Healthy Again movement. And another one is what I like to call the technology or AI question. What are some ways you anticipate that osteopathic medical colleges will integrate and maybe already are integrating artificial intelligence programs into their instruction?
So at the national level in the association, we're actually trying to wrestle with that question. We've actually brought on special advisors to help us with that question as we try to work in partnership with our colleges to figure out exactly how do you integrate this. And the key here is to not be too slow and not be too early, right? To learn what we need to learn so that whatever we integrate and we do well. The interesting thing for us has been a conversation about, can AI be used to help us get back to the things we think are most important? And throughout this interview, I've been talking about the importance of putting the patient at the center of the experience. But if we think about experiences in the past 2 decades with the rise of technology, all too often the physician's looking this way and the patient's back here, and the conversation isn't eye to eye, face to face in the way it should be. As D.O.s, it's about, as I mentioned, where do our hands in terms of the use of manual medicine fit into this care that can't be done with a computer. And as we think about things like ambient scribing that can potentially listen to what's happening in the room, let me as a physician be able to pay attention to you and give you the time that you actually deserve. What we're hoping is to, in our classrooms and in our experiences, integrate AI and other technologies in a way that allow us to maintain the high touch history, the high healing touch history that we've had, with the high tech that I think is available to us to offer a form of precision care to you that ultimately, down the road, done right, improves the relationship with the patient and allows us to have less waste in the experience in the system in terms of testing and unnecessary diagnoses that aren't really going to help to make you better and realize your health potential.
Our main audience is primary care physicians. What would you like to say to them, or what would you like them to know?
Well, I think throughout this, conversation, we've been trying to talk about our support for primary care. It is a integral part of our identity, and certainly a space where we want to be able to partner with organizations and individuals who can help us make a difference in the healthcare system here in the United States.
I'm Richard Payerchin reporting for Medical Economics. My guest today has been Dr. Robert Cain, the President and CEO of the American Association of Colleges of Osteopathic Medicine. Dr. Cain, it's been a great conversation. We've covered a lot of ground, and I hope we get to talk again sometime soon.
Thank you for having me. This has been a great interaction. I appreciate it.
Once again, that was Dr. Robert Cain, the President and CEO of the American Association of Colleges of Osteopathic Medicine, speaking with Medical Economics Senior Editor Richard Payerchin. On behalf of the whole Medical Economics and Physicians Practice teams, I'd like to thank you for listening to the show and ask that you please subscribe so you don't miss the next episode. And don't forget, Physicians Practice will be hosting Practice Academy's new practice management track on Thursday, March 19th, featuring practical, actionable education for physicians and practice administrators. You can register today by clicking the link in the show notes or by going to registration.physicianspractice.com. As always, be sure to check back on Monday and Thursday mornings for the latest conversations with experts sharing strategies, stories, and solutions for your practice. You can find us by searching Off the Chart wherever you get your podcasts. Also, if you'd like the best stories that Medical Economics and Physicians Practice publish delivered straight to your email 6 days of the week, subscribe to our newsletters at medicaleconomics.com and physicianspractice.com. Off the Chart, a business and medicine podcast, is executive produced by Chris Mazzolini and Keith Reynolds and produced by Austin Littrell. Medical Economics and Physicians Practice are both members of the MJH Life Sciences family. Thank you.